thank you very much, all the family, Dental XP. Always is a pleasure to be here and to share our research, because I never come alone. I want to introduce my team. This is part of the team that work with me in biotechnology, in dentistry. This is part of the team that work in surface, the team that work also in biomechanics, in the different design, in BTI. And this is the team of my dental lab. This is the team of my dental office. And this is my small orchestra, that the advantage is that we work all together. We work doing research in many different directions. Today, my topic is to talk about the different situation, the difficult situation when we are in front of the mandible with this big severe resorption. And I want to present that for all of you today, it's very easy to treat these cases with the different approaches. My first specialty was maxillofacial surgery. For that reason, I evolved to use a block graft for many years. And for many years, my approach was to take a block graft in the posterior area to obtain vertical growth. But really, today is not my approach. Today is to use extra short implants in the posterior regions, and in many cases, why not to obtain vertical growth? Is it predictable to obtain vertical growth in this direction? I think that today, if we use the tissue engineering, it's very predictable to obtain 1 or 2 millimeters the vertical growth. This case maybe is exceptional to obtain 4 or 5 millimeters the vertical growth, because in many cases we don't need to obtain so big quantity of bone. But what happens when we are in severe narrow crest? We have different approaches to treat these cases. I love it to talk about the narrow implant, because in many of these cases, to use the narrow implants is the great opportunity to offer to the patient immediate loading and to place fixed teeth the same day of the surgery. But at the same time, many times in the neighbor area, I do the split crest, I increase the volume, I improve the lip support, and in many other cases, at the same time, I use block graft with a Fouad-Curie approach to obtain horizontal bone growth. But what about the posterior region in the maxilla? For many years in this situation, I opened the sinus to make the traditional sinus lift. But today, my approach in these cases is to use extra short implants with a minimum apical growth. Obviously, in other cases, I continue using the conventional sinus lift. But it's very important always to know exactly which is our goal and which is the goal of the patient. The last speaker was talking about the pink papilla, but also it's very important to explain our patient which is our idea. Because in the posterior area, I think that this situation is a very acceptable situation. And when we have a very severe atrophic, this situation is also very acceptable for our patients, and we can finish the restoration with fixed prosthesis, and always I try to avoid the overdentures. Today, I want to talk about the extra short implants. These articles I published 8 years ago, but believe me, in the last year, I start to understand very well what is the meaning of this study. Talk about the extra short implant, that this was the last slide. I love it always to introduce what are the finite elements. With the finite element analysis, we can observe and we can simulate exactly the real experiment that we do in the lab. But with one difference is that we observe perfectly the distribution of the tension in the screw, in the bone. If we analyze very well what happened with the short implants when I loading, the distribution of the implant in the narrow implant are completely different that in the moment that we increase the diameter of the implant, the distribution of the tension in the bone decreased drastically. And we can observe that always the first threads receive the maximum tension. For that reason, it's very important to analyze that when we increase the diameter of the implant, the tension decreased drastically until one limit that the tension maintains more or less the same. For that reason, when we are in the area with severe resorption, it makes sense not to increase the length of the implant, to increase the diameter of the implant. This is the first message that I want to share with you. If we observe how are the distribution of the implants in the lab, we observe that if we compare one implant at 13 millimeters with one implant at 6.5, at the end, in both cases, the tension are in the first threads. Maybe the question is, makes sense to use normally implant at 13 millimeters, or makes sense to reduce the length of our implants? If we observe what happened when this implant receives lateral forces, we observe similar situation. When an implant receives lateral forces, also work the first threads. In these cases, maybe another thread receives tension, but always the tension are in the neck of the implant. Exactly the same situation when receive lateral forces, one extra short implant. For that reason, the first question is, makes sense continue using implant the 15 or the 30 millimeters? 30 years ago, when I started to place implants, my preference was the implant the 15 or the 30 millimeters. And today, in my office, I reduced drastically the length of my implants. And for me, one implant, the 7.5 millimeters, is a long implant. For that reason, what happens when we are in the posterior area? Makes sense to place two implants and reconstruction two single crowns, or makes sense to place two implants and splinting? Always that we splinting two implants, we reduce the lateral forces the 50%. For that reason, makes sense, for one biomechanics point of view, to splinting always the implant in the posterior region. At the same time, if you place two implants with two single crowns, the position of the implant will be in the middle. The advantage is that you splinting the implant, you can place the implant in the streams, that always you reduce the tension and always you obtain even better hygiene and better biomechanic result. It will be possible to splinting three implants, you eliminate deflector movement. For that reason, always will be a better situation, and this is maybe the best biomechanic situation in the posterior and in the anterior region. And in the moment that we splinting three implants, we reduce the lateral forces drastically, near the 300-fold. For that reason, it's very important to analyze if it makes sense today to place single crowns or make more sense to splinting the implant. When we talk about the extra short implants, again, we use the finite elements, and we observe the differences that what happened when I observe the distribution with extra short implants. The maximum tension will be 63 megapascals, but with a longer implant are exactly the same. For that reason, makes sense in the posterior regions, even in the sinus area, to place implant the 10 or 11 or 13 millimeters, or maybe make more sense to place implant the 5.5 or 6.5 or 7.5 millimeters. When we place extra short implants, obviously, we must do everything carefully, because I don't want to lose bone. I want to obtain vertical growth. For that reason, the biological preparation of the site is extremely important. I published more than 10 years ago. I am using last 15 years. I changed the protocol to drill, and I drill at slow speed. I drill normally a 100 revolution without irrigation. Why? Maybe the question is, why not? Why I drill slowly? If you drill at high speed, all the bone that you recover is powder. You destroyed the trabeculas, and the bone that you recover is not a live bone. If you drill slowly, the size of the trabecula that you recover is 10 times bigger. And the most important thing that I observe in the lab is a live bone. But also, the new alveolus are in much better biological situations. But what about the temperature? When I use the thermography, we observe that if you drill slowly, even the temperature maintains better than if you drill at high speed with irrigation. For that reason, today makes sense to change our protocol to drill, and especially in the area that you have a really limited situation. For that reason, makes sense to drill depending the density of the bone. We can change the different protocol. Why I love it to use the autologous growth factors? I am using this protocol last 20 years in post-extraction socket and maybe the last 18 years in implant dentistry. Why? The responsible of the bone regeneration normally is the blood clot. But today will be possible to change this concept and obtain one clot completely different. I remove the red cells, I remove the white cells. Why? Because contain pro-inflammatory cytokine, interleukin, and tumor necrosis factor, and also metalloproteinases that degrade the fibrin. The white cells is not our enemy, but do not offer any advantage. And this is the consensus in the literature. All the researchers have the same idea. For that reason, when we prepare my graft, this was the old clot that I used in maxillofacial surgery 30 years ago. But today, will be possible to obtain even a great biomaterial using the autologous proteins. And will be possible to obtain different therapeutic formulation. Will be possible to obtain liquid to prepare our graft. Will be possible to use liquid activate, like I showed you at the end of my lecture, to infiltrate the wrinkles, to improve the quality of the skin. Will be possible to obtain a clot with autologous bone or different biomaterial, and also to obtain the membrane. This is our approach for tissue engineering, and all my grafts always are sticky, are in a clot of the PRGF. I increase the volume of my graft, and at the same time, I obtain one graft that are sticky, and I can place exactly in the position. Now again, we go to the mandible. We have extremely severe resorption, only 4 millimeters to the nerve, which is our approach. I start to drill with the standard protocol. We can maintain 1.5 or 2 millimeters the security, and in this situation, we have one option today. We have the option to drill with one specific drills. One drill that I use a 100 revolution, and will be possible to drill exactly in the top of the nerve, even looking for the nerve. Why? Because you drill carefully. The drill is flat, and you have the perfect control. Don't make sense to use stopping the drill if you drill slowly, because you can see perfectly the lines of the drill. And after, you can place your implant. With this protocol, also, you can drill carefully, and after, with the bone that you recover drilling, we can place our graft. Like I show you in this picture, it's very easy to observe the line of the drill during the drill protocol. What happened now in the upper maxilla? For many years, when I have 5 or 6 millimeters of the residual crest, I open the sinus to do the sinus lift. In the last 10 years, I changed completely my approach. Which is my approach? I start to drill, like I showed you before, and when we are in this situation, I take the front attack drill, and now I drill looking for the Snyder membrane. it's not a nerve, it's more safe. I think that is the best approach to start with this technique, and you can looking for the Schneiden membrane. In the moment that you observe the Schneiden membrane, the drill is flat. It's very predictable. Don't damage the Schneiden membrane. And now, in the moment that you have the 50% of the window, you have room to condense the fibrin that you recover or you prepare with the PRGF endorette technique. And now is the time to place the implant. Why I didn't place any graft? Because I don't need to place any graft to obtain 1 millimeter the apical growth. I do experimental study in animals, and we observe that even it's possible to obtain 2, even 3 millimeters the apical growth if you wet the implant with PRGF endorette and if you use a good surface in the implant. For that reason, when I have even 5 millimeters of the residual crest, my approach is exactly the same. I'm looking for the Schneiden membrane. In the moment that I have the window, I condense the fibrin, and in many cases, you can place one implant the 5.5 millimeters. In other cases, maybe you can place a small graft. When I have 4 millimeters the residual crest, the conventional approach, again, is to open the Schneiden membrane, which is our approach. Our approach is looking for the Schneiden membrane, open the window, condense the fibrin, and in many cases, only with this, you can place an extra short implant. But always, if you drill slowly, you recover bone. For that reason, you can condense the bone that you recover, and to obtain 1 or 2 or even 3 millimeters, the apical growth is very predictable. And these are the different approaches depending on the length of the implant. If you place autologous graft, you can place a longer implant. But never today I looking for to place an implant the 10 millimeters or 8.5. In this situation, 6.5 millimeters is enough. What happens when I have just between 3 and 4 millimeters? I use exactly the same protocol. I open the window, I condense the fibrin, and in these cases, you can place a small quantity of the biomaterial, condense the autologous bone, and after you can place the implant. And this was really the change of the approach that I want to share with you, because I changed completely my protocol. Every year that I have more and more experience, I reduce drastically the number of the windows that I open in my office. Of course, when I have between 3 or 2 or only 1 millimeters the residual crest, our approach is the technique that I published 20 years ago, is to open the window with the ultrasonic. I keep the window. I prepare my graft. Always I wanted to place autologous bone, and I place the window again. I cover with fibrin. Observe that I prepare the biomaterial in a clot of the PRGF. You increase the volume of the graft, you increase the volume of the autologous bone, and at the same time, you have the great biomaterial and also increase the number of the cytokine to stimulate the bone growth. I published many articles and observed in this book, 20 years ago, I published the first article in the literature to use the ultrasonic device to open the window, and this was this book, and also I published many other articles. Now, I want to show you which is our clinical experience. In cases like this, between 5 to 4.5 millimeters, always I place implants no longer than 6.5 millimeters, and we can observe that to obtain 1 or 2 millimeters, the apical growth is very predictable, and we can observe in the CT scan that really the bone that I recover is 1 or 2 millimeters. We can obtain exactly the data. In this situation, also will be possible to obtain apical growth and a very stable result after 4 years. Exactly the same in other cases. With 6 years follow-up, we can observe the perfect stability around the implants. What about when the patient have a small inflammation of the Schneiden membrane? It's possible to place implant. You don't need to touch the Schneiden membrane. If you want, it's possible to open the window and aspirate completely the residual cyst. But in many cases, if the patient don't do this surgery, you can place extra short implants, and the results are really predictable. I published this article, and it's curious how observe that will be possible to increase near 3 to 4 millimeters in the apical growth using this protocol, using the PRGF Endoret. In other study, we observe with more implants 97% of success with this protocol. In the mandible, we are using exactly the same approach. We drill carefully. Always, I recommend to take experience first in the upper maxilla, but the advantage if you place a wide diameter implant is that really you open a good window. You can see with the loop of the microscope, and you can observe even the nerve, and of course, it's better to maintain 0.5 millimeters of security distance. After that, with the bone that you recover drilling, you can obtain vertical growth exactly the same that we obtain in the upper maxilla. Let me that I show you exactly which is the approach. This is the bone that I recovered drilling in a clot of PRGF. The advantage is that the proteins are sticky. You can place the graft exactly in the position, and after that, I cover only with a fibrin membrane. And after that, you can suture, and this was the result that we obtained. To obtain 1 or 2 millimeters the apical growth, if you use autologous bone, if you use autologous proteins, is really predictable in the hands that everybody in this room. But what about the proportion of the ratio implant to crown? I publish different articles because our results are exactly the same. Everybody can observe 6 years follow-up, the perfect stability. But what about with the ratio is 1 to 4? The results are exactly the same. We publish different articles that there are in the literature about the predictability of the long-term follow-up, 10 to 12 years follow-up, 99% of success. Let me that I present now one severe resorption. The patient lose all the teeth, but also lose the bone, which is our approach in these cases. Of course, we analyze the residual crest. In this particular area, the patient have a really narrow crest. What is possible to do in these cases? It's possible to increase the volume of the bone, but also will be possible to place a narrow implant and increase the volume too. In the posterior area, I use a wide diameter implant and, of course, an extra short implant, and even will be possible to do immediate loading. If you obtain a good primary stability, will be possible to do immediate loading. In this implant, I prefer to place my graft to obtain vertical growth. And this was the situation before and after. These are the situations when I do the second surgery that we observe in the 90% of the cases, that the cover screw is completely covered of the new bone. What about the upper maxilla? In this particular case, the patient have a really narrow crest and also only 3 millimeters or 4 millimeters the residual crest in the molar area. Which is our approach in these cases? Our approach in these cases is to take a block graft of the ramus, to use the Fuad Curie that I think that is a person that everybody knows, that changed completely the concept of the biology of the block graft, and really changed drastically my practice in this direction. In many cases, I do the expansion and use transitional implant to increase the volume. I place my graft, and this was the result. The advantage is that if you place transitional implants, you can do immediate loading after that. This was the position of the implant, and this was the volume that we obtained with this protocol that in the 100% of the cases, I use autologous proteins, and I use only autologous membrane. It's possible to use GBR technique, of course. My question is, we need to use this protocol because I think that this volume of bone is a good result too. This was the older hemiarcade, and we can transform a very narrow biotype with a very thick biotype. In these cases, always I love it to screw the prosthesis, and this was the result before and after. And this was the lip support that we obtained. In the posterior region, to obtain, like I presented before, 2 millimeters, the apical growth is very predictable. And in the mandible, to obtain 1 or 2 millimeters, the vertical growth is also very predictable, and this was the result in the mandible. And this was the case before and after. All the surgery I do in the office with IV sedation, and the patient, in many cases, will be possible to reconstruction with immediate loading with the narrow implant. This was the situation before and after, the X-ray before and after, and observe the difference of the lip support in the moment that you increase the volume in the upper maxilla and the different smiles. And really will be possible to change the face of the patient. But what about I reconstruction the bone, I improve the lip support? Is possible to do something more in these cases that have severe resorption? In the last 10 years, last 15 years, I am doing a lot of research in dermatologists to treat ulcers, to treat different injuries, and the protocol to increase the volume of the skin, I think that is really interesting. With the PRGF Activate, we can infiltrate all the face in just a few minutes. It's a very simple protocol, and everybody can introduce this approach tomorrow. I use a very thin needle, and the protocol is so easy. You can infiltrate the wrinkles, you can infiltrate the skin. But let me that I showed you before, which is the research that I do last years. Why? To analyze what happened with the photoaging. Because the sun destroyed many things. There are important things and symptoms of the photoaging, including the formation of the wrinkles, the free radicals, and the destruction of the collagen and the elastin fibers. In the lab, we do a lot of research to observe the cells proliferation and also to analyze the synthesis of the procollagen and the hyaluronic acid. I know that everybody knows the technique to infiltrate the hyaluronic acid, but my question is, why don't stimulate that the skin liberate or express this hyaluronic acid? What happened with the sun? And this is a message for all the women, but also for all the men. What happened with our face? The sun destroyed completely the collagen and the elastin, and we observe what happened with the cells that I exposed with the ultraviolet radiation. Destroyed completely the collagen, the vimentin, and the fibronectin. And we observe what happened in the lab exactly in the same situation if I place PRGF. We change completely the evolution. In other words, if you infiltrate the PRGF in the skin, you can protect the skin of the patient. You increase the thickness of the skin and also you can regenerate the elastin, like I showed you very soon. Observe what happened when in the lab we observe the fibroblast. We culture the fibroblast with the control, or in this area, I place the PRGF. In red, we can observe the apoptosis, and we observe that if you place the PRGF, you reduce drastically the number of the apoptosis in the skin. This makes sense. Observe what happened. I take 10 patients with a photoagent, and we take a small biopsy, and we observe that the skin was completely destroyed, the elastin. What happens if you infiltrate the PRGF? You recover the elastin, you increase the thickness of the skin, and of course, you improve the look of the patient, and all the patients are very happy. But observe the significant differences in the same patient. This was the elastin, and this was the new skin that you can regenerate, just infiltrate in your office the PRGF. We analyze the thickness of the skin, and we analyze how reduce drastically the elastosis. These are a clinical trial with the 3 infiltration of the skin between 2 or 3 weeks, and observe the significant result. This was the patient before, and this was the result after. For that, always that I treat a patient with severe resorption, always I finish my full rehabilitation, infiltrate the skin, infiltrate the wrinkles in women, and of course in the men too. All of this technique I publish different books, and today many of these books are in digital version. We publish more than 300 articles that support all of this biological approach. And to summarize, I think that today it's possible to introduce the tissue engineering in our office, not only to regenerate the bone, not only to treat the post-extraction sockets, also to regenerate the skin of our patients. Thank you very much for your attention.